Good evening. Welcome to our Digital Infoday Session. This webinar will cover what smouldering myeloma is, how it is different from myeloma, and how to live with smouldering myeloma. The webinar is being recorded and will be available to watch on our Facebook page and our website soon after. If during the webinar you'd like to chat to each other, you can use the chat box, and if you have questions for the speaker, please use the Q&A box at the bottom of your screen. I'm Suzanne, and I'm the Head of Clinical Practice Services at Myeloma UK. We are a patient-focused organisation, and we aim to empower, inform, and support patients in everything that we do. As an organisation, we rely on the generosity and kindness of our supporters, fundraising and donating. Myeloma UK receives no core government funding, so your support is vital, and we are truly thankful for all contributions as they allow us to continue working to help patients, their families and friends. This evening, I'd like to welcome Dr. Simon Stern, a consultant haematologist and trust lead for chemotherapy at Epsom and St Helier Hospitals NHS Trust, an honorary consultant haematologist at the Royal Marsden NHS Foundation Trust. Thank you for speaking to us this evening, Simon, and I'll hand over to you to start your presentation. Thank you.
Well, thank you, Suzanne, and thank you to everyone for joining the meeting this afternoon. I hope you find it useful and beneficial. I think Suzanne's already touched on this, but what the areas I would like to cover this afternoon, obviously smouldering myeloma itself. Now, one of the difficulties of this area of myeloma practice is the terminology, and so I'll be trying to explain how it's different from myeloma, or I think I'll probably use the term active myeloma more often during the talk. So active myeloma is myeloma that clearly needs treatment or is causing organ damage, whereas smouldering myeloma, as I hope we'll show, is something quite different. And we're going to also talk about how best to live with smouldering myeloma, because although it doesn't require treatment, it can be sometimes quite a difficult condition to live with. So I hope we're not going to bombard you with too much information this afternoon, but there are 3 take-home messages I'd like you to have at the end of the talk. Please don't let anxiety about your diagnosis take over, and obviously having more information about diagnosis usually helps reduce anxiety. We're going to remind you to be vigilant for symptoms or new symptoms that might suggest that smouldering myeloma might be progressing, and remind you to tell your healthcare team if you have any of those symptoms. And please do always remember to ask support when you need it. So smouldering myeloma falls into this group of conditions related to something called a plasma cell. Now, the plasma cell is in the bone marrow, and it's the cell that becomes malignant in multiple myeloma. But as a lot of you may know, there's a pre-malignant or benign state called MGUS, or to give it its very long tongue-twisting name, monoclonal gammopathy of undetermined significance. That never causes symptoms, and it's something that's monitored. Smouldering myeloma, the core of today's talk, is an early form of myeloma. Again, usually no symptoms at all, and again, certainly in the UK, monitored and not treated. And then, as I've alluded to earlier, active myeloma is the form of myeloma that produces symptoms, can cause damage to the organs, and therefore it's very important that we do treat it and we don't delay about treatment. So let's just have a brief look at MGUS. We've called it benign on this slide. I think that's a bit generous. Certainly it doesn't behave like a cancer, but I think there's a lot of evidence now to suggest it's a sort of pre-malignant condition. So certainly it doesn't cause symptoms. Certainly it's just something to be monitored, but there is a very small risk that it will progress to multiple myeloma, or requiring treatment, or smouldering myeloma. And the risk is sometimes difficult to quantify, but we usually, when I'm talking to patients, I I quote a 1% per year, or 1 in 100 patients per year risk of MGUS transforming to smouldering myeloma or active myeloma. So, smouldering myeloma is best, I think, thought of as an early form of myeloma. So it usually progresses to active myeloma, but it may be many years before this happens. And we've got some exact figures to give you later on in the talk. So certainly we do not treat smouldering myeloma as a rule, but it does need regular monitoring because it does have the potential to transform to active myeloma that requires treatment. And I think I'm going to sort of dwell on some of these points further as we go on during the talk. But those are the sort of the key cornerstones of smouldering myeloma and its relationship to active myeloma. So, multiple myeloma, or myeloma, is a sort of blood cancer. It arises from abnormal or malignant plasma cells in the bone marrow. And it's the condition that I suppose most people with active myeloma are discussing with Myeloma UK and their healthcare professionals. I think what's worth stressing is that there are now very effective treatments for multiple myeloma. I'm give away my age now, but I started as a hematology registrar about 30 years ago. And at that time, it was very unfortunate that there were very few treatments that could produce a really good response in myeloma. Now that is very different now. However, it does, as I'm sure some of you know, remain an incurable condition in the conventional sense. In other words, it's very difficult to get rid of all the myeloma completely, even with the best treatments, or at least get rid of it permanently. So the natural history of myeloma that's requiring treatment is one of treatment to get the patient to remission, and then hopefully a long remission and several years in many cases, and then an unfortunate relapse. But at the time of relapse, we still have treatments in our locker that we can give to patients and induce another remission. So remission, relapse, remission is the way, the natural history of the condition, and that's what some of you may already be living with, or some of you may already know about. But in asymptomatic or smouldering myeloma, that's the stage of the disease before active myeloma, and the cornerstone of treatment is monitoring alone. So, one thing I'm sure you have heard discussed or read about is the paraprotein. So, paraprotein is the protein that is produced by the malignant multiple myeloma cells, the plasma cells. The sort of protein it is an immunoglobulin or an antibody, and of course those can be very useful. I'm sure we're hearing all about antibodies at the moment in terms of in relation to the COVID pandemic. So all sorts of antibodies are being produced by normal plasma cells all the time. However, it is the malignant plasma cells in smouldering myeloma or myeloma that produce the paraprotein. And it's quite easily measured these days through blood tests, which we perform regularly, as we're monitoring patients in the clinic every time they come to clinic, or have blood tests prior to a telephone consultation or a video consultation. We all check the paraprotein level. On the right is quite a nice cartoon that represents a paraprotein or an immunoglobulin or an antibody. And as you can see, there are two main components, a heavy chain and a light chain, which are joined together. Some forms of myeloma, the malignant cells just produce the light chains, and you may have heard or you may have the condition light chain myeloma. So that is a form of myeloma where the malignant cells don't produce the whole paraprotein, they just produce the light chain component. I think I've already mentioned this, but do remember that the paraproteins are simple antibody type structures, and antibodies are very important to us. They help fight infection primarily. Sadly, the paraproteins aren't much use in that respect. And in fact, paraproteins or bits of the paraprotein can cause damage to tissues, notably the kidneys. So that's the key difference between normal antibodies, useful, paraprotein, unfortunately, potentially damaging. So let's go back to smouldering myeloma. How is it normally picked up? Well, the fact that it doesn't cause symptoms means that it's very often diagnosed completely by chance. A patient might be having routine blood tests as part of their monitoring of diabetes or high blood pressure or any condition, and during that follow-up, they find to have a high level of protein in their blood, and further investigations reveal that that high level of protein is due to a paraprotein. So that's often the first indication. Another way that we might pick up smouldering myeloma is by following up a patient with MGUS. So remember, MGUS is the stage prior to myeloma or smouldering myeloma. So many patients with MGUS have regular blood tests, either in hospital clinics or with their general practitioner. And it might be noted that the paraprotein level of an MGUS patient goes up quite sharply. And that might be an indication that the MGUS is transforming to smouldering myeloma. So we've got a patient with a paraprotein, a relatively high paraprotein. How do we diagnose smouldering myeloma? Well, it's very likely that we perform a bone marrow examination, which may well be familiar to many of you, and that would pick up an excess of malignant plasma cells in the bone marrow. You need 10% or more to make a diagnosis of myeloma. If you've got more than 60%, you've got active myeloma and need treatment generally. So it's between that 10 to 60% plasma cells where you'll find most of the smouldering myeloma patients. Paraproteins of more than 30 grams, that would be regarded as a high level of paraprotein, and that would by itself would be enough to make a diagnosis of smouldering myeloma, although you can have smouldering myeloma with a much lower paraprotein if you've also got an excess of plasma cells in the bone marrow. Very importantly, in smouldering myeloma, there's no sign or symptoms of any organ damage. So, for example, the patient would not be anemic, their level of calcium in the blood would be normal, and their kidney function would be normal, unless they've got another condition that might cause impaired renal function, like high blood pressure, for example. We would then, for all these patients, go on to do scan their skeleton in some way. We used to do something called a skeletal survey, where we perform lots of individual x-rays of several bones in the body, but it'd now be much more likely for the patient to have a whole body scan, either a whole body CT scan or a whole body MRI scan. Those sort of scans are very good at picking up bone damage, the sort of bone damage we see in myeloma, but in smouldering myeloma, no bone damage would be seen. And I think we're going to go on to have a look at the difference between more different streams, smouldering myeloma and active myeloma now. And so we've just drawn two columns there that sort of, I suppose, summarize what we've just been talking about. So on the left, smouldering myeloma, between 10 and 60% of malignant plasma cells in the bone marrow, the paraprotein in the blood, or sometimes just the light chains in the urine, or just the light chains in the serum, in the blood, but crucially, no signs or symptoms of organ damage. And to reiterate, these are the patients that are monitored in the clinic rather than treated. And on the right, patients with active myeloma who also may have exactly the same number of myeloma cells in the bone marrow, though, again, if it's more than 60%, they've got active myeloma, need treatment. They might well have bone damage on their scans. These whole body CT scans or whole body MRI scans might show bone damage due to the myeloma. They're likely to have a higher level of paraprotein in the blood or the urine, but not always. And they'll have tests that would indicate they've got organ damage. So, for example, when you do a blood count, you might find they're anemic. You might do their kidney function test and show kidney impairment. And if we feel that, for example, the kidney impairment's due to the myeloma, then that's a clear indication to start treatment. the bone damage on the scans, a clear indication to start treatment. So I hope I've managed to differentiate between the two forms of myeloma there. Smouldering myeloma, they meet the, if you like, the textbook definition of having multiple myeloma, but they're not, the myeloma is not active because it's not causing damage to any of the organs. So when we have a patient with active myeloma, we generally treat patients straight away. We don't want to delay. The question is, why don't we treat smouldering myeloma? And that's a question I'm often asked in the clinic. And I think this is one of the key aspects of it that some patients find quite difficult. They'll say to me, you've diagnosed I've got a cancer, and smouldering myeloma is a cancer, but you're not treating me. You're just going to monitor me. Why is that? And there are some good reasons for that. The benefits of treating smouldering myeloma have not yet conclusively been shown to be there. And why do I say that? Yes, if you treat a patient with smouldering myeloma, you can get their paraprotein level down. But if you follow these patients up in the long term, are you actually improving their long-term prognosis by starting treatment at that stage? And that's not been clear at all. And until perhaps very recently, the balance of risk and benefit have certainly favoured just monitoring patients. Because remember, the treatments we would give a patient have got potential side effects, including potentially severe side effects. And patients can go on with smouldering myeloma just being monitored for many years. Again, I'll show that again later in the talk. However, and this is where it gets a bit more complicated, you can sort of risk stratify, if you like, patients with smouldering myeloma into some patients who have a higher risk of higher risk form of smouldering myeloma that might be have a greater chance of transforming into active myeloma more quickly. And there have been some clinical trials looking at giving patients with so-called high-risk smouldering myeloma drugs like lenalidomide on its own, or lenalidomide and dexamethasone together. And they appear that they may show some benefit by doing that, just with the higher risk smouldering myeloma patients. But I should stress that these are sort of early clinical trials. They're not universally accepted, and it's not current practice in the UK to treat high risk smouldering myeloma patients. Might that change in the future? Well, yes, it might. Even if I wanted to treat someone under the NHS with high-risk smouldering myeloma, I wouldn't be able to because the drugs aren't funded for that use. But it's one of these watch this space areas of myeloma practice, I think. Right. I think we're going to pause there. We're sort of halfway through. But I think I think Suzanne's got some questions that have been pre-submitted, and which I hope will be of general interest and use to many of the audience. So I'm happy to answer them now.
Apologies, everyone, I was on mute. Thank you, Simon, and thank you to everyone who submitted questions. So the first question is, I'm a smouldering patient. Are there any signs that myeloma is progressing?
The answer to that question is there may be, but there may not be. So the signs that would ring some alarm bells, I suppose, would be new pain. Now, we always talk in myeloma about bone pain, and that's, I think people sort of know what that means, but the pains of myeloma are often quite non-specific. So I wouldn't just hang my hat on it necessarily being bone pain. If you're getting new pain of whatever sort that's persistent, we all get aches and pains now and again, but that's persistent, that might cause some concern. Fatigue is a very general symptom, and we can all, again, be tired for all sorts of reasons. But were a patient with asymptomatic myeloma to start becoming anemic, for example, they might get more fatigued easily, they might get shortness of breath on exertion, for example. On the other hand, it is possible for asymptomatic or smouldering myeloma to progress without giving any symptoms, and that is the real rationale for the regular follow-up that we do in the clinics, where we check blood tests on a regular basis, maybe every 3 months, every 4 months, whatever it is, and that may be the way that we pick up the transformation.
And I guess, Simon, coming back to pain, my impression is always it's sort of pain that doesn't get relieved just by the standard over-the-counter sort of pain relief medication.
Yes, I think that's a good point. You know, if it's a couple of paracetamol in, it's better for a long period of time. That's not classical myeloma pain. But if paracetamol isn't touching it, or if it's particularly if it's in the back and you've not been prone to back pain in the past, or the hips, that would cause some concern. And I think you should certainly make contact with your myeloma team in the clinic about that.
Okay, thank you. And thanks to Ian for our second question. So his question is, I have smouldering myeloma, and I was under the impression that if any of the CRAB criteria came into play, that is the signs and symptoms indicating myeloma, then I would need treatment. This does not seem to be as clear-cut as I thought. I get the impression that there are different protocols dependent on the primary care trust you are in. Could you clear this up for me, please?
Yes, that's interesting. First thing I would say is that if you're under myeloma hematologists or myeloma specialists who have got a good understanding of the disease, they will want to treat you. If you get these so-called CRAB criteria, or that, which is just another way of saying organ damage from myeloma or severe symptoms from myeloma, then that is a clear barn door indication to start treatment. And no, I think, primary care trust or clinical commissioning group would stand in the way of that. So although patterns of management may vary across the country, I think that's a sort of absolute sort of core of myeloma management, that if a patient gets organ damage or the so-called CRAB criteria, that is an indication to treat straight away, and there shouldn't be any delay. And I wouldn't be concerned that all the people in the county next door would get treatment for this and I wouldn't, because I don't think that would happen.
Okay, thank you. And my third question comes from Lynn. I'm suffering from neuropathy in my hands and feet. Is there treatment that I can access if I've not yet received treatment for smouldering myeloma?
The answer to that question is yes, because we sadly do see these sort of peripheral neuropathies, or the sort of numbness, tingling in the fingers, pain in the extremities that you described there. And yes, of course, you can have treatment for those without necessarily having treatment for the multiple myeloma. Now, it's quite a sort of specialist area, and not all hematologists are au fait with it, not all neurologists are au fait with it. So, but there are medications, there's sort of local treatments that can be used. I think a good starting point may well be your clinical nurse specialist, who may have her own expertise in that area, but it should be possible to be referred to someone who has expertise in painful peripheral neuropathy or symptomatic peripheral neuropathy that can cause disconcerting symptoms. And that may be in a variety of settings. It could be from a neurologist, it could be from a hematologist or clinical nurse specialist. It might be from a general practitioner. Some are very good at dealing with these sort of things. And there are also, of course, many hospitals have pain clinics. So do pursue it if it's a troublesome symptom for you.
Yeah, that's definitely good advice. Our next question is there anything that can be done to stop the progression of smouldering myeloma?
That is again a good question. We may be come to talk about non-chemotherapy treatments later, or so-called alternative remedies. One that I think people may have in mind when they ask that question may be turmeric or curcumin, or the curcumin is the sort of active component. And what I would say about that is there is scientific evidence to suggest that it might be beneficial, in as much as it works on little proteins in the bone marrow called IL-6, which is it's a promoter of myeloma cells, and it inhibits that. So does taking turmeric or curcumin slow progression? I think the jury's out. So in order to answer that question clearly, what you'd need is a randomized trial where you got 100 patients, you tossed a coin, 100 patients with smouldering myeloma, you tossed a coin, 50 of them got turmeric or curcumin, the other 50 got a placebo, and you followed them up. That trial, and you compare how well they did and how many of each group progressed to active myeloma. And that would give the answer. It's not been done. I don't know anyone who's planning to do it, because it's not the sort of thing a big drug company would finance, a study like that. It would be interesting. So I think the answer, Suzanne, is that there is no clear evidence of any intervention that slows progression, but there are one or two promising possible agents, and turmeric is one of them.
Yeah, thank you for that, because we get asked about turmeric a lot, as I'm sure you
do.
imagine. Yeah. So our next question is, we get asked a lot about genetics as well. The next question is smouldering myeloma inherited?
Absolutely not. I can be much more dogmatic about that. Multiple myeloma is what we call an acquired condition. In other words, the trigger to myeloma is something going wrong in the bone marrow that happens to you, happens within the bone marrow at the genetic level. It's not a genetic abnormality that you inherit from your parents. That said, yes, there are some families, if you look at families where there might be more myeloma in the family than other families, but that's not the same as saying there's a clear-cut genetic inheritance, because there isn't.
And then the next question is, what are the best ways to look after yourself as a smouldering patient?
Yeah, a good question. Well, the first thing I would say is turn up to all your appointments, all your monitoring appointments, because that is the cornerstone, as I've said before, of monitoring patients. That just these regular blood tests, if you haven't got symptoms, that is. Otherwise, it's just all the usual things: not smoking, good diet, keeping as active as you can, bit of exercise, no fad diets. Absolutely not, but just a good general diet. But there's no magic panacea that I'd recommend, but it's all the usual common sense things.
Okay, so thank you for answering those questions. So now we'll move on to the second part of your presentation.
Thanks, Suzanne. Okay, so back to the presentation. So, I mean, hopefully I've touched on this in the Q&A and a bit earlier, but so this really just centers on how we monitor patients with smouldering myeloma to pick up at the earliest possible time point that the myeloma might be progressing to active myeloma. So the regular blood tests, we check the paraprotein and the light chain levels, we do the kidney function tests, we check the blood calcium level, we do a blood count to look for anemia. We don't routinely repeat bone marrows, which are quite unpleasant, and body scans. We might do if we're concerned about progression. So if someone came with new pain in, say, the shoulder, it might be likely we might do an MRI scan of the shoulder. Or if the patient's become very anemic and the paraprotein's gone up sharply, we might do a bone marrow, but we tend not to repeat them very often. In terms of it's trends that are more important than one-off results, because although our laboratories produce very good, very accurate results, they're not perfect, the machines that measure these things like paraprotein. So I tend not to jump or get too excited about a single paraprotein result that's gone up a bit. However, were you to get 3 successive paraprotein results that were going up and the trend was clearly upwards, that might be a red flag to suggest progression is taking place. In terms of how often these tests are done, yes, we tend to do them every 3 or 4 months. If someone's very stable and has been stable for like years, 5, 6, 7 years, we might even go down to once every 6 months. But 3 or 4 months is the standard interval. So those are the blood tests, and then the bit we delegate, I suppose, to the patients is for them to be vigilant for new symptoms. And I think I've talked about some of these: fatigue, seen with anemia; pain, seen with progression within the bone and within the bone marrow; weight loss. One thing I haven't talked about yet is recurrent infections. Patients with active myeloma tend to be more immune suppressed than patients with smouldering myeloma. So if you start getting more infections than you did in the past, that might be a significant warning sign. So just a nice cartoon that sort of summarizes some of those symptoms. Fatigue, battery running low, pain in the back, or any new odd pain anywhere, to be quite honest, but we've back, rib pain, hip pain would certainly be warning signs. Kidney damage, no magic symptom of kidney damage. Fatigue might be one of them, but the blood tests are actually essential there. A fracture, that would be very worrying in a patient who's had smouldering myeloma, and we want to investigate them, definitely want to investigate them further. So, if I could take the right half of this slide first, patients with smouldering myeloma are often very keen to ask, so when will you actually start treating me? However, if treatment's not needed, if the blood tests are all stable and the patient hasn't got symptoms, we just carry on monitoring. And we want to carry on monitoring for as long as possible. Treatment, though, as we've touched on, as soon as those symptoms or abnormal blood tests become significant and significant enough to suggest that the transformation has taken place from smouldering to active myeloma. There's still always a little bit of a grey area, particularly if a patient hasn't got clear-cut renal damage, clear-cut bone disease, but you sort of get a feel when you get to know a patient that the time has come to start treatment. Because we don't want to wait so long that the patient gets really bad organ damage. Worst case scenarios, for example, in kidney damage would be complete kidney failure requiring hemodialysis or any form of dialysis. That would not be a good thing. So I think it's important. It's a two-way discussion with between the doctor and the patient, talking about progression of symptoms and blood tests, and then a time is reached when between both parties agree now would be a good time to start treatment, because we want to prevent severe or irreversible organ damage. I should say that the treatments of patients whose smouldering myeloma progresses to active myeloma is exactly the same treatment as those who present afresh with active myeloma. So I'm sure you're aware that some patients present with kidney damage or bone damage, and they need to start treatment straight away. But the drug treatment that those patients get is exactly the same drug treatment as patients who progress from asymptomatic to symptomatic myeloma. Timescales. This is, I think, very important to patients. Yes, the vast majority of patients will progress from smouldering myeloma to active myeloma. However, after 5 years, only half of the patients will have progressed to active myeloma. So that's half the patients after 5 years will still not have received any treatment. And after 10 years, 35% of patients still won't require treatment. And after 20 years, there'll still be 25% or a quarter of patients who will not have required any treatment. And that sort of underpins the reason why I was talking earlier about these trials that have shown benefit for treating smouldering myeloma. And that's why they're concentrating on the so-called high-risk patients, because if you treated everybody at the earliest outset, you'd be treating patients who might never actually require treatment, and that would be a shame, I think, because of the side effects of the drug. Very difficult for an individual patient when you see them for the first time and make a diagnosis of smouldering myeloma to predict which of those groups they'll fall into, whether one of the ones who transform within the first 5 years, or one of the ones who might not transform after 20 years. So that's where the monitoring comes in, and that's why monitoring is so important. And it is worth saying that the longer you go on having smouldering myeloma, the lower the risk becomes, because you can see the rate of transformation after 5 years decreases quite rapidly. So if you've got to 5 years and with smouldering myeloma and you still haven't required treatment, the outlook is even better because the rate of transformation goes down quite significantly. But every patient's different, and we don't. I'm always, sometimes get accused of sitting on the fence when I first see a patient and sort of hum and ha and hedge a bit about how fast their smouldering myeloma is going to progress. However, there are some clues that might suggest you're more likely to progress. So if you've got a higher percentage of myeloma cells in the bone marrow at the time of your diagnosis with smouldering myeloma, for example, if you had 50% as opposed to 15%, you'd have a higher risk. If your paraprotein or your light chain level was higher at the time of diagnosis, that might imply a higher risk. Or specifically, when we do the bone marrow examination at the start of when we make the diagnosis, we look for some genetic abnormalities that might put patients into a higher risk group of an early transformation. However, these are all about probabilities. That does not mean an individual patient will transform early. So I've got some patients with smouldering myeloma who've got some of these high risk genetic changes, and they've been followed up for several years now with no evidence of transformation. So how do you get on with your life when you've got smouldering myeloma? It can be difficult because of the degree of uncertainty and the anxiety around the fact that we've made a diagnosis, it's a blood cancer, but we're not treating you. And we're very aware that anxiety can peak just before a clinic appointment. Prior to clinic, you might come in a week early for your blood test, and from the time that blood's taken to the time you talk to the doctor or the clinical nurse specialist, your anxiety levels often go up, and we are aware of that. However, the upside of these regular tests are that by monitoring at regular intervals, we will pick up the transformation to active myeloma if it's happening quite early. It's easy to say, but we do recommend people keep a positive mindset and just get on as much as possible with a normal life. I mean, if there is an upside to smouldering myeloma, is that it does not cause symptoms. So, you are free to just get on with things. It's perfectly okay to feel down and particularly anxious on some days. That's very common. But if possible, not to let it take over your life. And anything that, any form of complementary therapy or mindfulness therapy that helps you, absolutely, we would recommend that because it can help to relieve that anxiety. So, having just said, get on with your normal life, which is very important, I would also say remain vigilant for symptoms that might be of concern. And we've talked about them: pain, fatigue, weight loss, unexpected infections or more infections than in the past. But a lot of these things are non-specific, so they might not be related to the myeloma progressing. Very much worth getting them checked out, but patients may be pleasantly surprised that when they have the test, the fatigue is not due to the myeloma, it's due to something else completely. So there's a whole range of people who can be supportive to you. Your healthcare team locally, your clinic. Myeloma UK is a fantastic resource for patients. There's the Myeloma info line, there's the Ask the Nurse email service, There are discussion forums. Choose which one you go on carefully. That's always important, as with any of these chats and support groups. Family and friends. Patients sometimes, particularly if they've got asymptomatic myeloma and they're not smoldering myeloma and they're not requiring treatment, they sometimes have difficulty deciding who they should tell, how many of their close family and friends they should tell, and there's no right or wrong answer to that. Clearly, it's what any individual patient feels best with. But for patients who need it, there are of course counselling and other talking therapies. And at the end of the talk, there'll be a slide which will outline the contacts for some of these support mechanisms that Myeloma UK provides. Smouldering myeloma is a very active area of research, and that's great because, you know, I talked about some of the clinical trials of treatment early on, but we also want to know which patients are more likely to progress to active myeloma, and therefore which patients might benefit from starting treatment at an earlier date. And the big question is, if we are going to, in the future, treat patients, what drug treatment should we use and how effective is it? And there's a big study that's, I think, is based at University College London called the Cosmos study, and it's looking at patients with smouldering myeloma and doing various relatively non-invasive tests to identify which patients are more likely to progress. So if we can identify high-risk patients, those are the ones that we want to put into the clinical trials of treatments, like some of the trials I talked about earlier in the talk. So I think back to Suzanne, yeah.
Yeah, so obviously now we've got some time for more questions. So the first question is, can smouldering myeloma patients access the same cancer support services as patients with active myeloma?
Absolutely, yes. Yes, I think it's very important. You know, patients with asymptomatic smouldering myeloma shouldn't regard themselves as a sort of second-class myeloma patient in any way. You know, these patients, if you've got it, you've got myeloma. You're absolutely entitled to the same support from clinical nurse specialists in the clinics, in the hospital clinics, and from organisations like Myeloma UK as patients with active myeloma.
Next question is, how likely is it that smouldering myeloma patients will receive treatment in the future?
Well, I think so much depends on these trials, Suzanne. I mean, I think it is fair to say that if we can identify high-risk smouldering myeloma patients, and some more trials produce promising results in those patients, I think it is very conceivable that in the future, whether it's 3 years from now, 5 years from now, whatever, patients with high-risk smouldering myeloma will receive some form of drug treatment. Now, we've got to be very careful with what drug treatment we give, because we don't want to give treatment at that stage that might make the patient feel worse or have long-term side effects that outweigh the benefits of starting treatment early. But that's what clinical trials are there to identify. And I think it is certainly conceivable that that is what will happen in the future, yeah.
And thank you to David for this question, because this one does cause confusion. Is smouldering myeloma the same as symptomless myeloma?
Yes, and you've probably heard me slip into my old habits during the talk, where I've talked about asymptomatic myeloma. So asymptomatic myeloma is symptomless myeloma, is smouldering myeloma. So it's essentially, they're all essentially the same things, and it's a sort of terminology issue. I've always quite liked asymptomatic myeloma because it's, as a term, because it does what it says on the tin. It absolutely tells you. Whereas smouldering is a bit more, slightly more abstract, but if that's the term that people are happy to use, that's fine.
And then we've got a question from Helen. What information is out there for smouldering myeloma patients who struggle with their mental health and find it difficult staying in limbo and not knowing what the future holds for me?
Yeah, well, I mean, I hopefully I've talked about them. I mean, maybe, Suzanne, you want to talk about what Myeloma UK in particular might offer those, because We, in the hospital-based healthcare professionals, we've got our support teams, our clinical nurse specialists and what have you, but I think you may be able to describe in more detail what Myeloma UK may provide to those sort of patients.
Yeah, I know we're actually working on a tool at the moment, so maybe Giselle or someone could put something in the chat about that. And obviously we have mention of some of our services at the end of this session. We've got some new questions coming in as well. So a question from Joe is, I was diagnosed with osteoporosis about 10 years ago. I was diagnosed with smouldering myeloma 4 years ago. If I break bones in the future, how will I know if it's simply osteoporosis or worsening myeloma? Wow, that's a tricky one, Simon.
That is a tricky one. I think what you should do in that situation is worry that it might be myeloma until proven otherwise. So if you broke a bone, I'm sure it would happen. Your medical team would do all the myeloma blood tests to see if there'd been any evidence of progression. Of course, patients with generalized osteoporosis break bones, and it might not be anything to do with myeloma, but I think it would be remiss not to investigate for possible transformation to symptomatic myeloma if a patient fractured in that way, yeah.
And I guess, I mean, not everyone who is joining us this evening will know that we've got this early diagnosis program, and Simon, you're on our early diagnosis steering committee. So you'll know we discuss this next one quite regularly in those meetings. So we've got a question saying, does everyone go through the 3 stages of myeloma? And the $1 million question is, should we be testing MGUS patients too?
Not everyone does. There's a big variety. So we've got some MGUS patients who we follow assiduously and nothing ever happens to them, and they stay with MGUS for their whole life. We have other MGUS patients we follow who transform to myeloma via smouldering myeloma or not. And sadly, the vast majority of patients still are diagnosed de novo, as it were, so they present acutely with multiple myeloma. It is very likely that they've had MGUS or even smouldering myeloma, but we just haven't known about it. And a lot of the work we're doing in the early diagnosis steering committee is to sort of reduce the number of patients who present acutely, particularly via A&E or present very unwell. We want to sort of diagnose patients at a much earlier stage before organ damage occurs. One thing that's very topical is, should we be screening patients? Screening maybe the whole population for MGUS and myeloma. That case has not been made. We're very expensive, and it might not be, the sort of thing that healthcare wants to put its resources into, but there may be an argument for targeted screening in the future, and that's one of the things we're talking about. Particularly high-risk groups might benefit from it. So some patients go through the 3 stages, but most patients I see in my clinic are presenting with myeloma, active myeloma, for the first time.
Thank you. And as we know, there's always a lot of interest in clinical trials. So one of the other questions is, are there any new clinical trials other than Cosmos in the pipeline for smouldering and MGUS patients?
Not that I'm aware of, certainly none that are recruiting at the moment, but that's not to say they won't come on stream soon. I have a feeling it won't be long before there's a UK trial in smouldering myeloma. The Spanish groups and the American groups have been a bit ahead of us, I think, to date, but I think we may well, I know people are thinking about it quite actively.
And Drew has a question: what is the best way to plan ahead for a potential myeloma diagnosis as a smouldering patient? I am not coping with the psychological effects and consequential stress this may have on my well-being. Will this accelerate the disease?
Well, yes, I'm very sympathetic to that, because I'm very aware, having spoken to a lot of patients with smouldering myeloma over the years, that it can be a difficult diagnosis to deal with. I don't think there's any evidence that if you are more anxious or more stressed, that will increase the risk of transformation. So, I mean, that's the first thing to say, and it's very important. No one has ever shown that there's a clear link between psychological stress and progression of myeloma. All I would recommend is the various support groups and mechanisms that we've talked about, and finding one that suits you. Not every support group, not every thing that even Myeloma UK offers may be suitable for you, but I'd like to think that somewhere along the line you will find someone who can be helpful in some way to support you through the diagnosis.
Mm. And then this next one's going to put you on the spot. So why do some countries treat smouldering myeloma and the UK doesn't?
Well, you are right. Well, if you were to go into the States and you were being treated by a consultant who believed strongly in the trial, the early results of these trials, that high risk smouldering myeloma benefits from treatment, and you were insured, you would probably get treated. I think you have to be a bit careful. One, you have to be absolutely sure you're identifying the high risk group, and we've got ideas about how to do that, but we're not absolutely certain. Secondly, you've got to choose your treatment appropriately, one that's not carries a high side effect profile. And thirdly, yes, I think it's best done within a clinical trial. I think until something's a proven benefit, it's best done in a clinical trial setting. But you're absolutely right. I think there are patients in other parts of the world with smouldering myeloma, hopefully high risk smouldering myeloma, who are receiving treatment at the moment.
And then our final question is a practical one. How do I explain smouldering myeloma to my travel insurance provider, and how will smouldering myeloma affect my holidays?
Yeah, good one. You may need to enlist your help of your consultant or a clinical nurse specialist, because I think I sometimes get asked to help with holiday insurance, and the first thing I say is this patient will not get unwell due to their myeloma while they're in Benidorm, Corfu, wherever, because they've not got symptoms. They're very, very, very unlikely to have developed symptoms within their fortnight of their holiday. They're not on treatment, so they're not getting any side effects of treatment. But you know, some insurance companies are more sympathetic than others, and you may need to enlist some help from your healthcare professionals to, or of course, just shop around for insurance companies.
So thank you. So that's all the time we have for questions today. So we can move on. Yeah.
So just to finish again with those take-home messages, really, that I started with. Difficult as it is, please try not to let anxiety about your diagnosis take over. Be vigilant for the symptoms that might suggest progression, and tell your healthcare team if you have any of those symptoms, and do please ask for support when you need it.
Okay, so I'd like to highlight some resources from Myeloma UK that you may find helpful. So we have a smouldering myeloma info sheet and a test and investigations info guide, both which can be downloaded from our website. There's also information available on the website itself. Simon has already highlighted other Myeloma UK information and support that's available. We have our Myeloma UK info line, our email Ask the Nurse service. We have a range of information publications, online videos, over 100 myeloma support groups. And again, you can find out more about those on our website. We have our patient info days, and of course, you're all attending one of our digital sessions this evening. And we have our online discussion forum. So we've come to the end of our webinar today. So thank you so much to Simon Stern for speaking and answering questions. And thank you for everyone who's joined us for the webinar. We're sure you found it helpful and informative. If we didn't manage to answer your question, or this has thrown up some new questions, please do get in touch with us. You can do this via the info line or Ask the Nurse email service. You can see the email address there, and also details of these are on our website. Keep an eye on our social media and website for announcements on further Digital Infoday sessions. And once again, I'd like to thank you for joining us. Simon, any last comments from you?
No, Suzanne, just I hope people found it helpful. It's always difficult to know how to pitch these presentations, but I hope it was at least vaguely comprehensible and of use.
Yeah, I think you did a great job, Simon. And to you and everyone else, I hope you enjoy the rest of your evening. Thank you. Goodbye.